please welcome Dr. Jim Hornstein.
Well, good evening. Welcome to our fourth Ethics in Healthcare program sponsored by the Community Memorial Health System. Mike and I have an inside joke about that. I've gotten that wrong the other four. So, Mike, how'd I do? Thank you. Okay. My name is Dr. Jim Hornstein. I'm the chairman of the ethics committees at the Ventura County Medical Center and the Community Memorial Health System. And I'm delighted to be moderating tonight's program. But first, a question. Is there anybody here in the audience who has attended all four other ethics programs, aside from my wife? Couple. Excellent. Very good. Well, I'm especially very happy to welcome you back tonight. And if you attend our fifth program, which will be in September, the few of you who raised your hands will be eligible for a free fruit juice and free salad bar at the Community Memorial Health System cafeteria. I actually just made that up. I did that to Goose Mike, who is the Vice President of Marketing and Development for the Community Memorial Health System. And by the way, speaking of Mike, I really can't go any further without mentioning several other people who have been so instrumental in putting on tonight's event and all of the events over the last half of a year. Specifically, I'd like to mention Mary McCormick, if she is here, Rick, Hugo, and all the other really wonderful staff who have put in so much effort to make tonight's program come together. And in addition, I'd really very much like to thank the Board of Trustees and the administration of Community Memorial Health System for really kindly and generously underwriting all these community ethics programs. So please join me in thanking all of those wonderful people. Thank you very much. So now let's begin, and to all of you, a happy National Healthcare Decisions Day. Now, I don't know how you usually celebrate National Healthcare Decisions Day, but for me, I can't think of a better place than to be here in Ventura in 70-degree weather to present our program. Now, I don't know if it's just you, but have any of you wondered why National Healthcare Decisions Day is on April 16th? And I think that there may be some bureaucrat somewhere hidden somewhere in the federal government who is just laughing his guts out because he has finally proven that old adage that there are two things guaranteed in life, which are death and taxes, right? So of course, yesterday, April 15th, was tax day. And so today, April 16th, is National Healthcare Decisions Day. Let's not be negative. I thought this would be an apt slide for National Healthcare Decisions Day. I'm not afraid of death, I just don't want to be there when it happens, by the great philosopher Woody Allen. So what are we actually doing here today? The National Healthcare Decisions Day was created actually several years ago to educate, to empower, and to inspire both healthcare providers and, most importantly, the public about the importance of advanced care planning and to reinforce the notion of patient rights. Today is really a day of collaboration between professionals and you, our community, to ensure that all adults have the information and the opportunity to discuss and document their own healthcare values and their own healthcare goals. Now, why is this so important? Okay, you have a reason to ask that. Why should we care? And let me give you several very quick reasons, but we'll go into that in much greater detail. First of all, this is a fact which perhaps most of you don't know, which is at the end of life, numerous studies have shown that 75% of patients will be unable to make some or all of their healthcare decisions for themselves. So that by the time you get to a very serious illness at the end of your life, chances are 75% of the time, 3 out of 4 times, we will not be able to ask you what you want because you simply can't tell us. And what's worse, we often do not prepare patients or their families to deal with these difficult and emotional situations before they arise. And I can share with you, as all our speakers will, the worst time to have these kind of conversations are in the emergency room or in the intensive care unit in the middle of a crisis. That is not the time for us to be saying, gee, I think we really need to get to that now. Okay? So that's hence the advanced care planning part, advance of any serious illness. Second, and this is also something which you may not know, and certainly I didn't know when I started researching this subject several years ago, number of studies show that doctors, no matter how long you have known your patients, don't really know what their patients want in end-of-life care unless they ask. Okay, doctors don't know. What's more, families often don't know what their loved ones want unless they ask. And here's the most interesting fact. Patients themselves are often unprepared and they don't know what they want, or they change their minds depending upon all sorts of factors. Okay, these are things which are important to talk about, again, before you're in a crisis situation. So what is the bottom line? Unless you have meaningful and clear conversations with a patient, no one really knows what another person wants regarding their end-of-life wishes unless we ask them. We have to ask. And that's where National Healthcare Decision Day comes in. What we are trying to do is set aside some time for all adults to give ourselves the benefit of thinking about what healthcare choices we would want for ourselves when we become really sick and unfortunately unable to speak for ourselves. So by being here tonight, we actually, as a community, are all saying we do not want to let this important opportunity be lost. So let us tonight, over the next hour, use this opportunity to learn and discuss about advanced care planning so that we can all make good and thoughtful healthcare decisions at the end of our lives. Now, I'm thrilled tonight to have an amazing panel of experts to lead tonight's discussion. Let me just tell you how we'll be doing this for those few of you who haven't been here before. As has been our tradition, each speaker will have approximately 12 minutes to present their subject matter. Now, after their formal presentation, we will have an opportunity for question and answer session. So right now, if you think, well, not right now, but as you think of questions as our speakers are going along, write it down on the piece of paper you have, lift it up, and one of our monitors will pick it up and give it to me, and we'll use that in the question and answer session. Following the question and answer session, we will conclude with, again, asking each of our speakers to have 2 minutes to give us their final and concluding remarks on the subject. So without further ado, let me turn to our wonderful guest speakers. We will begin with our first speaker with a historical perspective of CPR, Code Blues, DNR, advanced care planning by my dear friend and my colleague, Mrs. Diana Jaquez. Diana received her Bachelor of Science in Nursing from San Diego State University, where she also received her Master's in Science in Nursing, also at San Diego State University. She became certified as an advanced practice nurse in oncology at Scripps Hospital in the San Diego area and is board certified in hospice and palliative medicine. She is currently the clinical manager of the inpatient palliative care service at the Community Memorial Health System. And on a personal note, she is married to her wonderful husband, Dan, has 9 children and 2 dogs. She is also an avid motorcycle rider, if only she can stay healthy. It is my pleasure to turn the podium over to Diana.
Thank you. Oh, I didn't know you were going to give all that information on me. But let me just start by giving a little bit of background. I think it's important that we start by setting to the table with a few things you just might not know. Prior to the 1960s, most decisions about end of life were negotiated by the family and their primary physician, either in the office or in the home. And they focused on quality of life and pain and symptom management. Your grandparents or great-grandparents did not have to make the decisions that you're going to be asked to make in the future. The truth is, they lived hard. If they got sick enough to where their heart and lungs failed, they died. There were no ICUs. There were no heroic measures. They were not asked to make those type of decisions. So let's talk about what happened in the early 1960s that changed the tide. Prior to the 1960s, most hospitals did not have ICUs. And why was that? Because technology had not grown yet. Major advancements in new technologies, including advanced life-saving and supportive medications, defibrillators, cardiac interventions, and other types of procedures, allowed the opening of specialized units really focused to take care of our sickest patients. Now, equipment like ventilators that were used traditionally only in the operating room and post-operative were in the ICU. And sometimes they were used on patients that had life-limiting or end-of-life diseases and progressive diseases. That was never the intention of ventilators as they started, but as the ICU opened, that became the standard of care for all patients. Around the same time, the Boy Scouts developed CPR, or cardiopulmonary resuscitation, as part of their basic life support. The intent of CPR, which I must say is not a passive act. If anybody's ever seen a TV production on it, you see them do, and they breathe a little bit and they push a little bit. It's not a passive act, and it is nothing like you see on television. Was really meant to resuscitate previously healthy victims of drowning or electrocutions. It now has become the standard because it has been taught to most of the community by the American Heart Association, and it has become a standard for anyone who has a incident where their heart stops or they stop breathing, whether it be in the community or the hospital setting. This brings us to the code blue in the hospital. Originally, it was meant for very specific conditions. It was never meant to keep people with progressive diseases alive. In the absence of an order for a do not resuscitate, we do CPR and initiate ventilation on everybody in the hospital who stops breathing, regardless of their condition. Now think about the vast array of patients in the hospital, everyone from the pediatric patient to the 99 or 100-year-old patient who's coming in to the hospital. If they stop breathing, everyone receives the same treatment no matter what. No one dies in the hospital without these interventions being initiated, unless you have an order for a no CPR or a do not resuscitate. I know this might seem backwards, that you have to have an order to not do something, but every patient receives it unless there's an order to not do it. To this day, CPR is the only thing that you can get in the hospital setting without a doctor's order. Think about it. You can't get a Tylenol. You can't get a glass of water. You can't get a meal without a doctor's order. But everyone gets CPR regardless of the patient's condition or prognosis, unless you and your doctor specify that you do not want it. So this is the question. How did we get to where we are today regarding decision making? And I'd like to go over a couple of the two landmark cases that have led the way to the changes that we see today. First is Karen Ann Quinlan. Karen was the first case known as the Right to Die in the Right to Die movement. In April 1975, 21-year-old Karen was out with some friends, and she went to the bar for someone's birthday party, had a couple of drinks, took a Valium, and when she started to feel a little faint, her friends took her home and put her to bed. About 15 minutes later, they realized she wasn't breathing. They called an ambulance. They gave her mouth-to-mouth. They got her to the hospital, and she was admitted and placed on a ventilator with oxygen. It was determined after a few days that she was in an irreversible coma. So this is a 21-year-old person, previously very healthy. The Quinlan family struggled with this decision. They had very strong Catholic roots, and along with their Catholic council, decided that their daughter would never want to live it this way, and requested that the ventilator be removed. The court appointed guardians since Karen was 21. She was 22 at the time, just turned 22. said that the parents had no legal right to place that request because their request really was no more than euthanasia. The Quinlans took the case to the state court, who actually said that they agreed with the Quinlan family and that they could remove the ventilator. The hospital, on the other hand, took it up to the Supreme Court of the state of New Jersey, and who said that Karen could not be removed from the ventilator. After a time, the family took this back, reviewed it again with the state Supreme Court. Now, this is the first that has been taken up by the state Supreme Court at that level. And they were approved to remove the ventilator, and Karen lived for another 9 years on artificial nutrition and hydration. She eventually succumbed to complications of pneumonia and passed peacefully. The case set a precedent and established the patient's right to refuse medical care and control of his or her own medical treatment. It also changed the way that healthcare decisions are made, including the creation of ethics committees in hospitals, nursing homes, hospices, and home health agencies, as well as the creation of advanced directives and home health and healthcare proxies. Now, the next case is a case in 1983 of Nancy Cruzan. Nancy was driving down a road in Jasper County, Missouri, and lost control of her car, and was found later by a passerby in a ditch after an undetermined amount of time with no breathing and no cardiac function. Paramedics were able to restore her breathing and her heartbeat, but she sustained a significant time without oxygen to her brain. She was admitted to the hospital in a coma, and she remained in a coma for about 3 weeks, where the MD declared her in a persistent vegetative state. Now, this means that she has enough function to have her respirations and heartbeat continue, but she has no cognitive function, what makes a person who they are. And her ability to follow directions was gone. She was unable to eat or drink, so they placed a feeding tube. So she was not on a ventilator, so it didn't require that type of intervention, but she was in this persistent vegetative state. After talking with her roommate and her friends, it was found that she had had many conversations with her roommate that said, if I was ever in an accident and I was a vegetable, I would not want to live. The family, after 2 years of intensive rehabilitation, to them it became apparent that she was not going to regain any kind of cognitive or mental faculties. The family asked that the hospital remove the feeding tube, to which the hospital employees refused. The family argued that Nancy had many conversations with her close friend, and it was clear. But the hospital employees said no. So this went to the Jasper County Judicial Court, who agreed with the family and said, yes, you can remove the tube. Now think about the torment and torture this family is going through. 2 years of rehabilitation, seeing their daughter decline to a place where she's lying, contracted, she can't move. And the court says, yes, you can remove the tube. The hospital appeals to the Missouri State Supreme Court, who overturns the lower court's ruling and says, yes, we agree that every patient has the right to make decisions for themselves, but only if they are able to make decisions for themselves. And obviously, she's not in that condition. So the family now appeals to the U.S. Supreme Court. This is the first case that has ever been heard by the Supreme Court about the right to die. And the Supreme Court, after reviewing everything, and it definitely was a split vote, agreed to back up the state Supreme Court and uphold their ruling, but they made several statements along the way that have changed the way that we look at healthcare decisions. A couple of the things that they said were all treatment, including nutrition and hydration, are medical treatment and can be refused. That's a big one. The second thing is people still have the right to refuse, but if they are unable to tell anyone, each state must decide what level of evidence would determine their ability to make decisions. For example, basically the United States Supreme Court backed out of it, saying it's up to the states. And each state to this day still has a difference in what they call the preponderance, or how much evidence you must have. There's 3 levels. Simply, it is a preponderance of evidence in the court is about a 50% amount of evidence. And I don't think many states take that as a conclusive decision. A clear and convincing evidence is about 75% evidence. Now that would be if you told your doctor, if you told a family member. In this case, she did tell a friend, that would be her wishes. The third thing is beyond a shadow of a doubt. And I know we hear that in court trials. Beyond a shadow of a doubt is 100% proof. That is when you put it in writing, you make a decision, and you make it a legal document, and that's what we're going to talk about later today. This case and the U.S. Supreme Court statements led to the initiation of the Patient Self-Determination Act of 1991. This act requires that patients be given information about advanced healthcare decisions and directives upon admission to medical facilities. That's hospitals, nursing homes, home health agencies, hospices. And they have the right to facilitate their own healthcare decisions, the right to accept or refuse medical treatment, the right to make an advanced healthcare directive. The Patient Self-Determination Act encourages everyone to decide now about the types and extent of medical care they would accept or refuse if they became unable to speak for themselves. And in reality, when people end up in the hospital, many of them are not able to speak for themselves. The purpose of the Patient Self-Determination Act is to inform patients of their rights regarding decisions toward their own medical care, and to have the right to complete an advanced care plan that reflects their own values and wishes. So this is very different than what your grandparents had to decide. And I think that's what people, as you look through the history of this, it's amazing that we see 2 very influential cases of very young people. And that is probably the most difficult thing that we look at here. It's not the sick people, the one who has a chronic illness. So we're going to talk a little bit about advanced care planning, advanced directives, and what we call POLST forms, and talk about when they're appropriate and how to utilize them.
Thank you, Diana. Okay, so extra credit. Who was the attorney for the state of Missouri who argued in favor of the state against Nancy Cruzan in 1989 and 1990? And Judge, you're the only one who can't say. Oh, you don't? Okay. Anybody know?
Dr. Bernstein.
Dr. Bernstein. No. No, nobody? So the attorney who argued on behalf of the state of Missouri was someone who soon became very famous, was Attorney General John Ashcroft, who became the Attorney General under George W. Bush in his first administration. And he argued very persuasively and actually won the case. It was actually a very interesting case, the Cruzan case, because the people who were right to not have withdrawal of life support actually won the case, and the Supreme Court said states have the right to set their own level of evidence. So they won. But what was interesting was the people who were for more patient rights, believe it or not, also felt they won. Why? Because Sandra Day O'Connor, the first woman justice of the Supreme Court, wrote in a dissenting opinion that even though states have certain rights, individuals have the right to refuse any and all medical treatment at any time, including nutrition, hydration, ventilators, antibiotics, Band-Aids, whatever they don't want to take, patients at any time per the Supreme Court. So this is a constitutional right now, have the right to refuse any treatment that any hospital or doctor ever recommends. So again, both people in this particular case actually came out thinking they had won. And again, this case, interestingly, went on, was appealed again, more information came, and finally, unfortunately, Nancy Cruzan was able to withdraw her feeding tube because she wasn't on a ventilator and she died. Okay, but it was a very important case for the rest of us because that case led to, as Diana said, the law, which has been the law in the books since 1990, 1991. So we've had that for what, 21, 22, 23 years, that says all of us, you, me, everybody in the United States, this is national, federal law, says that you have the right to refuse any and all treatment. You just have to tell people. The problem, of course, occurs, what if you can't tell people? What if you're in a coma or a vegetative state? And so that's the segue for our second speaker. Our second speaker is Dr. Charles Pankratz. Dr. Pankratz will discuss in detail the Advanced Directive Form, the California Advanced Directive Form, and what all of us should think about why we look at to fill out that form. Let me give you a little bit of information about my dear friend Chuck. Chuck attended the University of California at San Diego as an undergraduate with a bachelor's degree in animal physiology, which helps him in Ventura being able to take care of people. Bad joke, Van. He then attended Chuck attended UC Davis School of Medicine, where he graduated, and then moved down to the Los Angeles area, where he attended the UCLA Harbor General Hospital, where he graduated with a degree in his residency in internal medicine. He actually spent an additional year after finishing his internal medicine residency as the chief resident of Harbor General Hospital. Chuck is board certified in hospice and palliative medicine, and currently he is the medical director of palliative care at Community Memorial Health Systems. He is also the co-founder and president of Ventura Care Partners, the first and only outpatient palliative care service in Ventura County. On a personal note, Chuck is married to his wife, Tricia, who is herself an exceptional endocrinologist. He has 3 children and a Labrador retriever named Rufus. Ladies and gentlemen, my dear friend, Chuck Pankratz.
Thank you all for attending, and I'd like to thank my panel for attending very much. Hugo, I'm going to have you run these slides because as a doctor charged with pulling the plug, I tend to avoid buttons and switches. So today we're going to talk about advanced care directives. No heroics. I like romantic comedies better. Next slide. An advanced healthcare directive is unique to every state. Not all states share the same rules for an advanced healthcare directive. So each state looks at how to maintain the autonomy of the patient, what constitutes informed consent, and what people can act as a durable power of attorney for healthcare for a patient. We're going to talk about 2 categories contained within that advanced healthcare directive. One of them is the power of attorney for healthcare. Who do you assign? Who do you trust? Who do you think best represents yourself as an individual when you are medically ill and decisions have to be made about future medical treatment? The other is the instructional directives for healthcare. Simply, I want all things done that medical science allows within reason, or I do not want a lot of interventions. If the doctors do not think there is a reasonable expectation, I will survive and recover. Next slide. So, you stole my thunder with death and taxes, but even death himself gets audited. So, Ben Franklin famously said, in this world, nothing can be said to be certain except death and taxes. The important thing to understand about an advanced healthcare directive is that it really reflects a quality of life assessment by an agent that you assign to represent your medical wishes, and also to determine what constitutes your ability to go through aggressive medical treatment and its associated burdens. The power of attorney for healthcare designates a person to make medical decisions. They're usually specified to make decisions only when the client can no longer make the decisions for themselves. We call that informed consent. Does the patient understand the risks, the benefits, the burdens, and the alternatives to treatment? Now, we don't always vet all those equally, but when we define as physicians, nurses, nurse practitioners, or anybody in the healthcare community, when we define informed consent, we want the patient to know the good, the bad, and the ugly. The durable power of attorney for healthcare equals a healthcare agent and a healthcare proxy. So all those terminologies represent the same individual. Next slide. It's important to recognize you need not have power and you need not be an attorney. Anybody can simply be designated as a durable power of attorney. In so doing, we can assign those who know us best, both those who know us personally. The instructional directives for healthcare are simply written instructions describing the treatments the patient would want or not want under certain circumstances. The important thing to understand about the instructional directives is that nobody, even myself as a physician, can anticipate every single clinical scenario on which we have to look at what the patient would and would not elect. That is why, if I prioritize things in the advanced directive, it is assigning a durable power of attorney for healthcare who can directly relate with the medical staff and the hospital staff in order to arrive at a decision given the current clinical circumstances. They include instructions about life-sustaining treatment, as Diana said, CPR, feeding tubes, ventilators, pain medications, and organ donation. Uniquely, California is one of the few states in an advanced directive where you can assign and make a decision about organ donation. That is not uniform across the country. And these are also known as living wills because the designation for what you want is while you're still living. So here is one a gross example of how to draft an advanced directive. In this slide, kill me if I have a headache, kill me if I'm itchy, and kill me if I complain too much. Well, he says I might have some edits, and he says there's your complaining again. So you designate what you want. Next slide. So what are the legal requirements? It's valid if a competent person is over 18 years old. Should include a person's name, their signature, and the date executed. Though I don't like executed, I recommend accomplished, completed, done, lightens the mood. I do not suggest other synonyms, including carried out or finished off. Number 3, it is acknowledged by a notary public or signed by 2 witnesses. One person must not be related or named in the will, so that eliminates my kids. And maybe my wife. Person's physician or healthcare provider or their employees. This is sort of a sticky one, because if you look at how the wording is, it says that it cannot be your acting physician. So how they define that is really very unique, particularly in how physician services are provided to patients. You now no longer just have the family medicine doctor who follows you through all levels of care. You now have a hospitalist, your family medicine physician, you have subspecialists. So the assignment of a physician as your durable power of attorney for healthcare is very uncommon. Some of the people that cannot be durable power of attorneys for healthcare, to summarize the last 2 bullets, are those people who have any responsibility as an employee of a healthcare organization, including a hospital, or anybody who operates a residential care facility. If you're in a nursing home and you have 2 witnesses, again, the other option is a notary. If you have 2 people that are witnessing this, one of them has to be an ombudsman or a patient advocate. So you can't just grab 2 people off the street at the bus stop and say, would you please witness this for my mother in the nursing home? It doesn't work that way. Next slide. So we tried everything. It was the kindest thing to do. He had no quality of life. They pulled the plug. Now last month I had a patient's son ask me, as we were doing end-of-life care, doctor, when are you going to pull the plug? I said, we don't pull the plug anymore. We're wireless. After he got over the initial shock, I then said, no, it is entirely up to you when you decide to remove a ventilator. The hospital nor myself will implement a time in which we elect to withdraw the treatment. Next slide. So who should have an advanced healthcare directive? Everyone with 2 arms, 2 legs, 1 head, and everything else that comes with it. No one who plans never to have an accident or become ill. They're eliminated. Any patient who's healthy before the onset of serious illness. We specify that because we think conversations at a family barbecue are more useful than conversations in an emergency room or an ICU. That is, a patient and a family who are not immediately under duress given the clinical circumstances. So these should be made with comfort. They should be made without the least amount of distress in the life of the patient and in the life of the person who is that durable power of attorney for health care. Patients with multiple chronic illnesses affecting their ability to live independently and engage in personally fulfilling activities. Again, the reflection of a durable power of attorney for health care and an advanced directive is not about life or death. It is about quality of life. Those at the end of life to express their values and preference to family and friends. We should all try our best to arbitrate as patients what we want to have done instead of making our family. So, you remember the 20 extra years you added for life through clean, healthy living? Well, these are them. Just a reflection. I don't smoke. I drink. And frankly, as a wife who's an endocrinologist, I eat sugar. So I must be a bad guy. Key components of a successful advanced healthcare directive. Open dialogue between the healthcare providers and patients. If you are a meticulous individual and you read the whole body of that document that is in front of you, it'll specify that one of the duties of the clinical staff, the physicians and those rendering care to patients, is that they need to discuss the current situation and provide a language and an understanding of the illness and prognosis that makes sense to the patient and or the family or whoever is the durable power of attorney for health care. So in my field of palliative care, that's what we often do, is just sit down, make sure the language and the condition is well understood by the family or that individual charged with the responsibility of making decisions. You need to reassess an advanced healthcare directive over time. There's no time frame for the validity of an advanced healthcare directive. So if you wrote it 20 years ago, it is as valid as if you wrote it 20 days ago. But unless you found the fountain of youth, there may be things that happen in those 20 years that may alter your directives. Or, quite frankly, most families don't live like the Beavers or any other television family. The discord can sometimes undermine the validity of who you assigned. In fact, they say the advanced healthcare directive is invalidated if you are married and then you divorce. So they say at that point in time, the divorced spouse no longer can be a durable power of attorney for healthcare. I would modify that to say sometimes they are the best one, but it certainly is a decision of the patient. I don't think I'd want an angry ex-spouse, ministering over my well-being. So I finish off with, you're going to be told you have 6 months, but with aggressive treatment, we can help make that seem much longer. Thank you.
I like that last slide. I don't know if you've seen that. Thank you very much, Chuck. But I'd appreciate if maybe in the back, one of the people with the video cameras, if you wouldn't mind focusing on Dr. Pancratz for just one more second. I've worked with Chuck for a number of years. He is a superb palliative care doctor, and I have never seen him wear a tie. So could we please... This is, and no stains. Thank you very much. So we've seen this, okay? This may be the last time. We'll see, yes. Our third speaker, it is a delight to introduce Dr. Leslie Lynn Pawson, who will speak about the POST program, explaining, first of all, what the heck is the POST program, and explaining what it is, and secondly, why we believe that the people who are sickest in our society, certainly in our state and our county, ought to be having conversations with their doctors to fill one out. By way of introduction, first of all, Leslie Lynn is a dual citizen of both the United States and Canada. And so, Leslie Lynn, on behalf of everyone who saw Argo, I would like to thank you very much from all the American side of that. Leslie Lynn did her undergraduate degree at McMaster University in Hamilton, Ontario, Canada, where she had a double major in psychology and biology. She attended medical school also at McMaster University, and then made the big trek to Northridge, California for her family practice residency at the UCLA-affiliated hospital in Northridge in the San Fernando Valley. She then went on to join a family practice in 1982 to 1990 in Simi Valley, at which point she left to join the faculty at the Ventura County Medical Center, where she has been an academic teacher since 1990. She has risen to the position of Associate Director of the Family Medicine Residency and is also an Assistant Clinical Professor of Medicine at UCLA. She is double board certified in family medicine in addition to hospice and palliative medicine, and is currently co-director of the palliative care service at the Ventura County Medical Center. In addition, in her free time, she is currently the Chief of Staff of the Ventura County Medical Center and is also certified in HIV medicine. In her other spare time, she has been married 38 years, so we know she wasn't born in California. Bad joke, all right. She has 3 children, and she participates actively in family triathlons, which I did not know what that meant. And what that means is she does the ocean swimming component of a triathlon, her husband does the biking component, and she grabs one of her 3 kids to run, okay? So with that, it is a delight to introduce Dr. Leslie Lynn Pawson.
Good evening. It's a pleasure to be with you. And you've got to love Ventura when I look out into the audience and I see the woman who was the beloved first grade teacher of those 3 children that were introduced. She was the first grade teacher of all 3 children, and she's in the audience tonight. So I'm going to talk about POLST, the what, the why, and the how. How many of you have ever heard of POLST? Can you please raise your hands? Okay. That's actually a higher percentage than the general population, which I will show you. So our first question is, what is it? So POLST stands for Physician's Order for Life-Sustaining Treatment. So think about that. It's a physician's order for life-sustaining treatment. That's different from what Dr. Pancras was just talking about, because that is your individual patient determination of what you want for your healthcare decisions in the future. This is a physician's order. So it's a standardized medical form indicating which types of life-sustaining treatment a seriously ill patient wants or doesn't want if she gets sicker or he gets sicker. It's a physician's order recognized throughout the medical system. It's a portable document. You carry it with you. I don't mean to dinner. It provides direction for a range of end-of-life medical treatments, and we're going to go through the decisions that it covers. It's really 3 questions that you and your doctor have to answer when you're filling out a POLST form. It's brightly colored. You can see a pile of them. They're pink. And it's a standardized form throughout the entire state of California. The organization in California that actually promoted it in California is the California Coalition for Compassionate Care. And it became law, meaning it became a form that needed to be honored if you filled it out in 2009. Is it mandated that everybody with a serious life-threatening illness that is close to the end of their life fill one out? Of course not. But if you do fill one out, it is mandated that we honor it. So what again is it? It's a form that helps you and your doctor have a conversation about these 3 main questions that are facing you if you have a serious illness and you get even sicker in the face of that serious illness. So why? Well, your doctors, your nurses, your healthcare providers don't often know what you want. This allows you to tell your healthcare professional what you would want at the end of your life. This was a study done by the California Healthcare Foundation. And they asked this question to thousands of Californians. If you were seriously ill, would you like to talk with your doctor about your wishes for medical treatment toward the end of your life? Well, you can see that 47% said definitely, 32% probably, 16% maybe. There's only a few percentage that don't want to. Have you ever had a doctor ask you about your wishes for medical treatment at the end of your life? 92% no. Most of you want to talk about it, and most of us don't talk to you about it. We need to change that. The same study looked at what were the most important factors at the end of life to the people that they asked the question. Can you see those? Okay. First one, making sure family are not burdened financially by my care. Top, 67%. Being comfortable and without pain, 66%. Being at peace spiritually, 61%. Making sure family is not burdened by tough decisions about my care, 60%. That's actually important and refers back to one of the things that Dr. Pancras was talking about. When you decide on your surrogate decision maker, when you decide on that trusted person that is going to make healthcare decisions for you if you cannot, don't burden them with making the decisions without talking to them about what those decisions should be. The surrogate is not to make decisions the way they would or the way they imagine that you might. The surrogate is there to make the decisions the way you tell them you want them to be made. So don't burden your surrogates, tell them what you want. What's next? Being able to pay for the care I need. We could say a lot about that. Making sure my wishes for medical care are followed, 57%. Not feeling alone, 55%. The 1/3 from the bottom, living as long as possible, 36%. Some 36% of the people that were questioned wanted to live as long as possible. I would urge, when you are having a conversation with your doctor, if you have a serious, very serious illness and you're talking about end-of-life decisions, that you talk about what that time might look like. And I'll explain as we go through some cases. So awareness of end-of-life terms. Look at the bottom. 13% of the population that was asked, had they ever heard of POLST, had ever heard of it. There was more than 13% of your arms went up. So you are an informed audience. So who needs a POLST? Someone with a chronic progressive illness, and I don't mean osteoarthritis, that is making us have more and more difficulty walking. I mean a serious health condition that's chronic and progressive. If you're medically frail, and the way doctors look at it is if someone has an illness and it is serious enough that we think that that person may not be alive 12 months from now, that's probably the person to have a POLST conversation with. Does it replace the Advanced Healthcare Directive? No. No. Because as Dr. Pancras said, everybody who's over 18 should think about having a Advanced Healthcare Directive. POLST is for people that have chronic, serious illnesses that are going to get worse and that you do not think will be alive a year from now. So at age 18, complete an advanced directive. Update your advanced directive periodically. Like Dr. Pancras said, if you get divorced, you might want to update it. But if you're diagnosed with a serious or chronic progressive illness at any age, that's when you should complete a POLST form. And then hopefully your end-of-life wishes will be honored. This is what it looks like. let's go through the decisions. Remember I said there were 3 decisions? So I've explained what a POLST is. I hopefully have explained why, and now how. So here's the first question. I have very severe metastatic cancer. It can't be cured. I know that. And I'm going to get sicker. If I get so sick that my heart should stop, or I'm not able to breathe well enough to keep myself alive, I have 2 choices. I can say to my doctor, if that happens, if my heart stops, or if I cannot breathe well enough to keep myself alive, I want you to try to restart my heart. I want you to put me on a ventilator and breathe for me. Or, I don't want that. I want you to ensure that I'm comfortable, and I want you to allow for my natural death. That's choice number A. And why might I choose, I want you to allow for my natural death? Because maybe my doctor and I would have had a conversation, and I know that with the advanced illness that I have, if I get that sick that my heart stops, the chances of me surviving are unbelievably small. And I don't want to spend that last little bit of my life in an ICU. Question number 2. My heart's beating and I'm breathing fine, thank you very much. But I still have my serious illness and I get sicker. I get a pneumonia and I'm very short of breath. And I have several choices, or have a choice to make. I can say, you know, this may be my way out. I'm dying. I'm getting sicker. This might be my way out. I have pneumonia. I want you to make sure I'm comfortable, make sure I don't feel short of breath, keep me at home with the people that I love, and allow for my natural dying. Or you could say, you know, I want you to give me antibiotics. I want you to give me oxygen. I want you to do chest physical therapy. I want you to do this, this, and this, and see if I can get past this. And see if I can recover from this pneumonia and live a while longer. Or you could say, I want you to do all of that section that I just talked about, and if I cannot breathe enough on my own to keep myself alive, I want you to put me on a ventilator and do all that aggressive care as well. So there's question number 2. Question number 3. I know I have this serious illness. Let's say I have advancing dementia. What happens with advancing dementia? With advancing dementia, one of the things that happens is that we lose our ability to swallow. Just the mechanics of swallowing become too much for us. And if that happens, and I can't eat enough to keep myself alive, I have a choice. I could say to my doctor, offer me whatever food and drink I can eat and drink. And if it isn't enough to keep myself alive, so be it. Make sure I'm comfortable and allow for my natural dying. Or I could say, I would like to have artificial nutrition supplied, bypass my mouth, bypass my swallowing mechanisms that aren't working anymore, put a tube in my stomach, and provide me with artificial nutrition so that I will stay alive longer. So those are your 3 questions with POLST. These are really hard, aren't they? Like, are you happy now? No. No. See how hard it is to discuss this stuff? So why is it that 92% of doctors don't bring it up? It's difficult to do. And it's also difficult for you to bring it up to your doctor. But think of these questions that we were just talking about and how important they are to determine how you want the end to be, if the end is here. And the POLST enforces that your decisions will be honored. So who can speak for you? Well, if you filled out a POLST with your doctor, you have just spoken. So let's say you have an advanced healthcare directive and you have determined a surrogate decision maker. Can they change your POLST? No. The burden of your surrogate decision maker is to only make decisions as you would have done so. And your POLST has made those decisions. You can change your POLST. I mean, let's say you decide when you first go through it that question number A is, yes, I want to have you restart my heart, and yes, I want to go on a ventilator. And B is the same, aggressive therapy. And C is, I want to have artificial nutrition. And 4 months, 5 months, 6 months go by, and your quality of life has declined such that you now think that the burden of doing treatments that prolong your life are no longer worth the quality of life. You may want to change your POLST. You can do that. Does that make sense? The surrogate may not change the wishes of the patient that were expressed by the patient before they became unable to speak for themselves. Examples. 76-year-old male with terminal, widely metastatic renal cell cancer without dementia. All right, so he's perfectly capable of making his decisions. Absolutely alone in the world. Breaks your heart, actually, as a doctor when you come across this. And he had gone through very, very aggressive treatment, and it was failing. I mean, it was not succeeding in prolonging his life. And when he left the hospital, he was no longer able to care for himself, and he was going to go to a nursing home. He had no one else to care for him. And when he was leaving the hospital, he had conversations with his doctors that he did not want to be, did not want his heart to be attempted to be restarted if it should stop. He did not want to go on a ventilator if he could no longer breathe on his own. He wanted to be comfortable, and he wanted to allow for his natural dying in a natural way. But he didn't fill out a POLST form. Doctor didn't think to do it with him. And he was discharged to the nursing home. And I would bet that several people in the audience have seen a form at a nursing home that's called the Preferred Intensity of Care form. And it has some of these questions on it about what you would want if, what would you want if, under certain circumstances. But he was handed this form by a non-medical person, an admitting clerk, and therefore that person couldn't possibly have a conversation with him about the intricacies of these decisions. And he filled it out all by himself in a way that reversed what he had decided when he left the hospital. But kind of out of confusion, really, and fear, and not having a caring person with him that knew of his prior decisions. And sure enough, he got sicker, and if I'm remembering correctly, it was that he was not able to breathe on his own. His lungs had been kind of compressed with malignant fluid, and he was rushed to a different hospital, and he was intubated, and he was ventilated, and he died in the ICU, which is not what he wanted. If he'd had a POLST form, that lovely bright pink form, if he'd had a POLST form, that would, the nursing home staff would never have requested that he fill out that other form, which is not legally binding, and he would have been protected from having things done to him that he did not want. 82-year-old male with advanced dementia, living in a skilled nursing facility, and currently full code. So remember, our first presenter said, what happens if your heart stops anywhere in a medical facility in the United States of America? CPR. The default position is CPR, right? Full code. Default position is full code. And maybe that's what he would have wanted. But advanced dementia at that stage means that he's barely speaking, can't do any of the things that he needs to do to care for himself. He is bedbound. Chances are, I mean, not 100%, but chances are that's probably not what he would want. But we don't know. Because while he still had the ability to tell his physicians or his family what he would want, never had the conversation. Oh, and therefore, when he couldn't eat anymore, to keep himself alive, his children wanted him to have an artificial feeding tube. And this happens a lot. And why would they make that decision? They love their dad. They think that's the right thing to do. You know? But if he had had a conversation with his doctors and then brought in his children, maybe he would have wanted the feeding tube, but maybe he wouldn't. Because is the burden of the treatment, the artificial feeding tube, is it worth the quality of life? Well, that's up for the individual to make that decision. Thank you.
So, thank you so much to all of our panelists. We have some time for some question and answers. If you have some questions lifted up, they will bring it to me. I've got a couple, so we'll start as we go along. And this is to anyone, if the three of you want to fight this out, we can. Would you please, let's just begin. Why, as we talked about, the number of people that have filled out advanced directives or POLST forms is running about 26, 27%. And as I mentioned, advanced directives have been around about 23, 24 years, POLST about 5 years. Why do so few people fill these out? They don't want, okay, let's open this up. They don't want to talk about it, right? It's just too hard to talk about, right? They don't know about it. Okay?
And actually, when, like what I said, anytime anyone is admitted to a medical facility, they are offered the information and they're offered the form. What happens then is those forms end up on a coffee table somewhere because the patient may not want to have that conversation at the time. They wait until they're feeling better, and then the conversation's not so important anymore. And like I said, the form ends up sitting on a coffee table someplace. That's why I'm really glad that we have an opportunity to speak today and get that information out. And one of the things that I've got to tell you is that dealing with families that are at this precipice of decision making, the decision whether or not to go forward with advanced treatment or to transition somewhere to a comfort, that's the difficult decision. What's easy is filling out a form. And if you can fill out that form, have it notarized or witnessed, that is the gift that you're giving to your family because now they know what your choices are, the person that you've named as a surrogate. And if you look at that, and as we look at our satisfaction surveys of patients and families after they've been in the hospital, the ones that have filled it out and know what their family wants, those are the ones who have left the best legacy.
Advanced directives, one of the reluctances really to talk about death, but you know, in sort of the context of the joke of death and taxes, that's not really what an advanced directive is meant to do. We all know that our death is inevitable at some point in time. It's the manner on which we decide what is the impact of disease management and treatment on changing that course of death, and in what circumstances will our bodies finally fail. My personal advanced directive very specifically states I want no pureed foods in pastel colors. I was a baby once, that's it. So my wife very understands that I'm not to have a Jell-O mold that looks like grapes. If I can't eat it and enjoy it, then that's not something I want her to extend, and she knows full well to just take the tray away. But all joking aside, it's a quality of life assessment I make and not really the manner on which I'm planning to avoid or delay the onset of death.
Here's a follow-up question to that. I like this very much. How do we bring up POLST and advanced directives with family members who the family members don't want to speak about it and don't think it's important to talk about it this time? So you want to initiate the conversation. Your family says, you're fine, I can't handle this. How do you address that?
Well, and we see that a lot, that the patient wants to talk, after they've spoken with their physician, they want to talk with their family. And the family will say things like, well, you can't give up, or you're going to be fine, even though we know they're not going to be fine. And I think it's important for the doctor to get involved then in how can I help you talk with your family? Because there's this chasm between the family and the patient. And the patient often doesn't want to hurt and burden their family with this painful discussion. And the family doesn't want to admit that things are the way they are for sometimes kind of magical thinking that if you say it out loud, it'll happen. And if you don't say it out loud, it won't happen. I mean, we do think like that. It's very scary. So I would ask the patient to ask their physician or the physician to offer to their patient that they could help them talk with their family. That, I think, often kind of bridges the chasm.
We treat, we're an inpatient service, but we also do outpatient work. One of the reluctance, the way we deal with reluctance is to deal with it as a grief response. Grief is not about dying, it's about any threat to our health and our survival. It's an innate response in all of us. So when we have a family that says, I'm really uncomfortable talking about my dad passing away or my mom, or I'm really uncomfortable talking about my spouse passing away, we try to go out and treat it not as a reluctance, but rather as a grief response. And we try to deal with that grief so that the patient and the family have a platform, or the decision maker has a platform with which make decisions based on quality of life and not on a grief response, not on a fear of death. And addressing that often helps bridge the gap, particularly when a patient is in the hospital and is critically ill.
And also, there are other formats for decision-making that have some more gentle language. There are a couple of forms out, one of them being the 5 wishes. And as you look through the 5 wishes, it talks about the same information that's on the standardized state form for advanced care directives, but it asks them, it gives you language to speak with family. Instead of saying, I legally appoint Susie Smith as my decision maker, and here's her address and here's her phone number. It asks many questions, and those questions are put in a way that can initiate conversations. For example, one of the first ones says something like, I know that I'm healthy today. I really would like to talk with you about what my wishes are. If I, A, B, and C, and it talks about quality of life issues. It talks about, I want to be pain-free. I want to be able to be in my home and be independent as long as possible. I want to be able to have my family around me. It starts to talk in questions and that will engage the family and allow that opportunity to talk in normal language about the things that are important to the patient, not just who do I name and what do I want if my heart stops. It includes those issues, but it also talks about the other things that are really important to quality of life. And I think that as you start to have that conversation with a reluctant family member, it eases their shoulders a little bit, it eases the conversation, because now you're not talking about life and death situations. You're not talking about life and death decisions. You're talking about how to honor the family member's wishes. And there are a number of forms out there. 5 Wishes is one, and if you have access, you can find that on the internet. So.
I think that's actually a wonderful question. I know in my own experience talking with families with or patients with advanced illness, it is not uncommon for family members to say, oh, don't tell mom she has cancer. Please don't tell them how sick they are. Okay, we don't want to disturb them because that will really make them worse. And I think there are a variety of tools that all of us know how to use to address that, but I think we do live in a society that getting older and getting sicker and finally looking at the end of our life is really not encouraged. And in fact, it is a kind of cultural American thing that we just don't want to look at this. Okay, Leslie Lynn made that point. If we don't talk about it, well, then it doesn't exist, which I think is a very big problem because we tend to infantilize. Not only is the poor patient sick, but then we pretend they're not sick. And if you typically ask people with advanced illness, gee, your family is a little concerned about this. What do you know of your illness? They say, well, I'm dying. And does your family know? No, we don't talk about it. Okay. So we have this sort of culture of non-disclosure, which we really have to overcome, because it's hard enough to deal with these subjects than to actually deal with this sort of culture of non-disclosure, of sort of denial, which really serves nobody's purpose. Okay. This is a great question. It's somebody who's extremely practical, whoever this is. Thank you for this. So number one, it says, do I need both a POLST and advanced directive? Number two, does a POLST supersede an advanced directive? Number three, every time I go into the hospital, do I have to fill out another POLST and advanced directive?
I will start off with question one. Yes, you do need both. The availability of the POLST document is very important. It's primarily driven by the inconsistency in respecting patients' wishes between a hospital, a home, a nursing home, and emergency response personnel. We would write DNRs in the hospital. Unfortunately, the ambulance drivers would not recognize that document as being appropriate. The POLST said we all agree, no matter at what level of care the patient is seen, that these are their primary wishes and expectations for treatment. The advanced directive is when you have time to review with the patient, the family, in a manner over hours or days. A POLST document is meant to say when you hit that emergency room door and you're brought in, should we put you on life support? Should we resuscitate your heart? The ambulance drivers are not going to look at an advanced directive and respect those wishes because they are intentionally vague. It is not the purview of an ambulance driver, an emergency medical technician, to decide what is and is not a terminal illness. That is something that has to be reviewed between a medical professional, the patient's decision maker, and family.
Remember, though, that when Dr. Pankrat says you need both if the answer to the question, do I have an illness that is so severe, progressive, that I'm not likely to be alive in 12 months, that's the person who needs both. If you do not have that kind of illness, you don't need a POLST yet. See the difference?
See, I think that actually needs to be reinforced. When we began the talk, Diana brought up several cases. The most interesting case, when you think about end-of-life cases, you sort of immediately picture a very elderly person with all sorts of horrible diseases. The main cases that have actually been used to form the law and the ethics of end-of-life care have all been young women, okay? Nancy Cruzan, 24 years old during her car accident. Terry Schiavo, 24 years old. Karen Quinlan, 21 years old. All of these women were previously healthy before their illness, but they were all over 18. All of them could fill out an advanced directive, okay? Not all of them, in fact, none of them should have filled out a POLST because they were previously healthy. The advanced directive is the most important document for everybody. You're over 18, you fill out an advanced directive. You have a life-limiting illness with 1 year left to live. Theoretically, you fill out a POLST form, okay? So it really is different, but this is a conversation for 18, 19, 20, 21-year-olds, because again, where were these laws made? They were made on healthy young women, not elderly people at the end of life. Okay. There have been several questions on this. It's a simple answer. Nothing is simple in this field, but it's relatively simple. If I fill out a California Advanced Directive and a POLST form in California and I travel out of the state, will it be honored in a different state?
It depends on the interpretation of that state as to whether it is a valid document. The state of California accepts all advanced directives from other states, but the states don't necessarily all extend that same courtesy. There are certain things that they require of an advanced directive that may not be fulfilled with the California Advanced Directive. To answer the second question from the one done previously, an advanced healthcare directive always supersedes a POLST document. When there is time and options available to the patient for treatment. The example is somebody who fills out "do not resuscitate." Yet they come in with a condition such as a pneumonia, where the doctors have some reasonable expectation that 2 or 3 days of ventilator support will actually reverse the patient's condition, and that their quality of life before they became ill was satisfactory. So I've actually reversed DNRs on POLST documents, talking with the durable power of attorney for healthcare, because in my opinion, the patient would do better with ventilator support, and therefore specified my reasons why. And in that circumstance, the advanced healthcare power of attorney agreed with me, and we intubated the patient.
So there are a number of questions as we get toward the end of our session that are a little bit edgy. Are you guys in the mood for get a little controversial here? Are we? Okay, yeah, so this is a feisty crowd. Okay. Fair enough.
Are you in the mood for answering?
Are you? So the first question is, what is a death panel? Is a death panel the same as a POLST form? Aren't advanced directives and POLST forms really just a way for the government to save money?
What was the last question? What was the last part?
I asked you if you wanted these questions. You're not allowed to groan, okay?
This is
Come
one
on.
for the moderator.
So the question is, what is a death panel? Are POLST forms and advanced directives just forms of death panels? And aren't advanced directives and POLST forms just a way for the government or your insurance company to save money?
The death panel is actually an appeal by a patient in order to terminate their lives based on their preference for not surviving any longer. Death panels do not exist in the United States, nor will they ever exist within our lifetimes.
Only in the eyes of Sarah Palin.
Yes. So, agreeably, Ms. Palin did say.
All right, this is getting fun. Okay, all right.
There's no political discourse on that one. It's really for anybody that you only hear the clean jokes. We do not have death panels in the United States. There is no panel that reviews the validity of a request by a patient to terminate their lives. We do have physician-assisted suicide in some of the states, but that is entirely a relationship between the patient and their doctor, and not a relationship from an objective panel. There is the Dutch experience for both adults and children in appealing to a panel to decide whether a patient is justified in terminating their life. That is not what is expected in the United States. And for those of us that practice hospice and palliative medicine, the official position statement does not support the institution of death panels, and I doubt in our lifetimes we will ever realistically have that put forward as a discussion for our population. The government will already impact your decisions regarding treatment. What we do with these advanced directives and POLST documents is do our best to return the decision back to the patient and to the family. We are here to make sure that the patient and the family fully understand the condition and the reasons why the prognosis for survival and recovery is poor. Any cost savings that are realized are entirely patient and family centered. Our team in palliative care, for instance, does not care whether the patient elects aggressive medical treatment or not, even in a terminal condition. What we want is a sophisticated, informed decision by the patient and/or their family that reflects their wishes and quality of life. When that happens, noticeably, the costs of health care go down. But that is a secondary outcome, and one that is not the parade point for these discussions about advanced directives and POLST documents, because these are patient and family and decision-maker-centered decisions.
Leslie Lynn, did you want to chime in?
Talk more about Sarah Palin? No.
Well, she lives a little closer to Canada now, so we're...
Right by the Canadian Parliament.
I was just in continuation of what Dr. Pankratz was saying. We don't care whether the patient decides very aggressive care in the presence or in the face of a terminal illness from which they are not going to recover. How I interpret that is it's not our decision. Like, it's not, we're trying to get at the patient's and the family's decision. If the patient and family decide that they want to spend their last 3 weeks of their life in an ICU on a ventilator, I care because I know that to be a suffering death. But I don't care to make the decision for them. It's not my decision. It's their decision. So advanced directives are not to determine what your doctor thinks you should choose. It's to determine what you would choose. And hopefully, with information from your physician and all of your healthcare providers and the nurses, et cetera, you would be making an informed decision. Most of us don't know that when we have metastatic cancer that can't be cured, that we've gone through many different courses of treatment and our cancer is still progressing. Most of us don't know, without a conversation with our doctor, that if we get sicker to the point that our heart stops, our chances of surviving to going home are 0 or almost 0. So it's not about saving money. It's about saving suffering.
We have 2 more questions. One is one that actually somebody asked and I thought was quite profound. And it speaks, it may be a little more personal than our speakers would like to speak to, but the question is, do doctors and nurses pick different choices when they select for themselves for advanced directives and POLST forms than they see their patients select? Meaning, do we in the profession who spend all of our time in hospitals and taking care of patients do different things than we see you do?
We are talking about what would physicians and nurses choose. The answer is simple. We don't want a lot of aggressive treatment at the end of life. We only are trying to exercise the options available to the patient so that they understand that they can choose aggressive treatment if that is their wish. But if you query doctors about what they want and nurses, they would tell you, don't put me through all that stuff. Because they understand that the potential burden of that treatment is far greater than the benefits, and that oftentimes it leads to ambiguity, indecision on the part of the family, and then they feel compelled that they are ending the life of the patient and not recognizing that this is a natural process, death.
And you know, I've got to say that since I was an early teen, I've had an advanced directive. My husband and I both ride motorcycles. And I don't know tomorrow that we won't take off and do something, and he may have to make a decision for me that, you know, I have had multiple conversations with him. We jokingly said, I'm going to have a do not resuscitate or a DNR tattooed on the roof of my mouth, so when they open my mouth to put that ventilator in, they'll get to see a do not resuscitate. But truthfully, you know, everyone has their limits, and I know that I have many colleagues that would give my husband advice. He is my decision maker. That is clear. I have multiple children that would all probably argue with him because they're going to have their own thoughts about what my quality of life would be. No one knows that better than me, and no one knows it better than my husband because we've had those conversations. But I'll tell you, as a clinical professional, I would limit the amount of interventions only because we've seen the worst. And we've also seen the best.
If you haven't heard this, then I would ask you to look at National Public Radio's podcasts, because NPR did a wonderful program just a week and a half ago that looked at the decisions that doctors make regarding the aggressiveness of their care at the end of life. I want to kind of distinguish. If I was electrocuted tomorrow, I would want to be resuscitated, right? I don't have, luckily, at least as far as I know, I don't have right now a serious, chronic, debilitating, progressive illness that is going to result in my dying anytime soon. So if I got electrocuted yesterday, I would want you to resuscitate me, thank you very much, and hope that I would get through it and be returned to a quality of life that would be worth the burden of the treatment. But if I had heart failure that had resulted in me being hospitalized 6 times in the last year, I would say, you know, the next time, because I barely got off the ventilator this last time, the next time I can't breathe well enough on my own, I want you not to take me to the hospital. I want to be kept comfortable. Why? Because I've seen too many people die after 3 weeks on a ventilator in the ICU from progressive, serious illnesses that are going to result in their dying anyway.
So we have time for one more question. Do you want to get a really nasty question? Yeah, all right, one nasty question. So this is actually moving in a different direction, and it says, does an advance directive give me, the patient, the right to demand a treatment which my doctor does not want to do?
Yes, you can demand that treatment so long as it is medically reasonable. We cannot have a brain transplant, though I was once asked if that was possible. I said, you will get a new brain, but you will get a different personality. If there is a circumstance where the physician does not agree with the decision made by the patient to elect a treatment, then it is the responsibility of the physician to say that is morally, that is ethically inappropriate in my opinion, but I will find a physician who will assist you with whether that is medically or surgically feasible. So you do try to establish that with the patient, and oftentimes you can fix that problem. If not, then you call that man in the dark navy suit an ethicist, and you ask whether it is ethically appropriate that we respect the patient's wishes, and then we try to work on that in a very constructive manner. It's not meant to be confrontational or to try and discourage the patient from treatment. Most of the time, when that comes to the forefront, it usually just takes a lot of discussion to figure out whether that really is their wish. Again, many people have an extraordinary grief response when somebody is medically ill, and when they do that, they may be compelled to expect extraordinary outcomes that are just not deliverable to a patient in a serious terminal illness.
There are also many circumstances in which someone may request a treatment, and the condition of the patient is such that that treatment would actually result in harm rather than benefit. I've been involved in that circumstance many times and have been able to help the patient understand that we won't do that, because not only will I not help them, but I will hurt them. And it's rare that you can't come to a understanding.
I think getting toward the end of this discussion, that is such a great question, whoever asked it. And I think what all of our speakers would be saying is when you have a conflict between what the patient is demanding and what the physician thinks is in their best interest, that is the beginning of the conversation, not the end. Okay, and that simply means that we have to have more conversations to be able to have that kind of shared decision-making to come to a reasonable conclusion. However, having said that, the law on advanced directives are very clear. Advanced directives let you refuse any treatment that's offered. It does not let you demand anything. Okay, so in other words, if a patient came to me and say, I have back pain, I demand heroin, and I have an advanced directive that says that, I can say, I understand that and have a nice day. Okay. So again, it's very important that you realize that advanced directives give patients the right to accept or refuse any recommendation made by their treating staff. It does not give them the right to walk in and say, you don't understand, I want absolutely everything that I want, whether it makes any scientific or medical sense at all. But again, that's another conversation of resolving conflict at the bedside, which is beyond the scope of today. Having said that, it's time, I should just share with you, you don't have the opportunity to see this, but I must have 20 to 25 questions. 24 of them are excellent. So this is obviously an opportunity to have more conversations on this subject. But it is our tradition to allow our speakers to have the last word. So maybe in reversed order, Leslie Lynn, and then Chuck, and then Diana, if you could have your soapbox.
The two slides that I showed you that indicated that many of you want to have conversations with your doctor about what you would want in terms of the aggressiveness of your health care at the end of your life. And then the second slide showed that 92% of the time you don't have that conversation. Your doctor has never asked you. So I would just urge you that you ask them. You can pick up I don't know whether any of you in the audience are in a circumstance in which a POLST form would be appropriate. If you are, take a POLST form with you and ask your doctor, or for you or for a family member. Bring it up to them. There's a very interesting statistic that the closer the relationship between the doctor and the patient, the worse the doctor is at prognosticating the future. So the more we know you, the better we know you, the more we love you, we think you're going to live longer. It's true. So that primary care physician that hopefully you all have, there's a lot of reluctance on their part to bring it up. So have the courage to bring it up to them, and hopefully that they will then respond.
It is very important to have three individuals present during a constructive decision regarding healthcare treatment: the doctor, the family or decision maker, and the patient. The advanced directive is meant to represent the patient and nobody else. That advanced directive is meant to have a constructive conversation between those three individuals, even if one individual is not present or able to make those decisions. We must appreciate the dignity and legacy of every single patient and not define the circumstances of their life by a terminal process that we will all go through. I leave you with one thought, and that is, we need to take back health care to represent the patients and the families. We cannot let the health care be dictated by dollars and cents We need to have healthcare dictated by those people who participate in the healthcare process, including the patients and the families. And we turn that tool over to each and every patient, respecting who they are rather than respecting their disease.
And I just want to close by thanking you all for being here tonight. I think this is a really important topic. And if there's anyone here tonight that is interested in filling out an advance directive or who would like assistance with it, now, once again, the POLST form, the bright pink form, you can take, whether it be you, a family member, one of your parents, to your physician and have that filled out with the doctor. I'm talking about the advance directive, the white form. If anyone is interested in doing that tonight, we'll be here. There's plenty of witnesses around. We don't have a notary, and actually, you don't need one. So there's plenty of witnesses that we can help you sign off each other's forms. But you know what? The more important thing is that you take it home, you look at it, and that you initiate it, and don't let that become the coffee table decoration that I talked about earlier.
Ladies and gentlemen, thank you all for coming here tonight. Thank you to our wonderful speakers. Don't forget the salad bar by attending our September meeting, and have a wonderful evening. Good night.